I'm Alicia Yamin, and I am in the Global Health and Population Department at the Harvard School of Public Health. I direct a program on health rights of women and children. I think I learned a lot from being on the steering committee, and it was a pleasure to meet some of these people in person when I came here. I think the multi-sectoral dialogue works better in some countries than in others. And I think that the experience of Salud, Derecho, as far as I can tell, has borne that out. No, absolutely not. I mean, most health systems in the region and around the world are tremendously inequitable and exclusionary, and often the way people experience, especially women and children, which is the area I work in most, they experience their poverty and marginalization is through their contacts with the health system. And those health systems often reflect prejudices and discrimination of the larger society. And that's the case in the United States as well as elsewhere. So I think it's the kind of those fissures within health systems and reinforcements of exclusion and marginalization need to be challenged. Well, so just to take a step back, the technical guidance on maternal mortality actually came as the culmination of 3 reports that the Office of the High Commissioner for Human Rights had done at the request of the Human Rights Council. First, establishing links between maternal mortality and human rights. What are the issues that connect the two? Then second, looking at best practices with respect to maternal mortality. And then finally, the technical guidance was the first time that the council had said, let's take a human rights issue outside of the Ministry of Foreign Affairs, the Ministers of Justice, et cetera, and really out of international law and abstract concepts and principles, and really make it operational. So it's the most of any UN document that has gone through an intergovernmental process, it's the most concrete in terms of what does human rights mean for policymakers, for decision makers in ministries of health. After it was approved by resolution of the Human Rights Council, there have been a whole series of initiatives, both on the part of governments and on the part of UN technical agencies, but also on the part of civil society actors, taking pieces of it to implement at regional and country level. So, for example, in the health sector strategy planning process for certain countries in East Africa, the principles, the way sexual and reproductive health is addressed there's an attempt to integrate them into those planning processes. In other countries, there is now being an attempt to try to address budgeting in a different way. And there's sort of very concrete things that a human rights-based approach would do differently. For example, we would be less concerned with aggregate outcomes in terms of number of maternal deaths reduced, and more concerned with inequities and disparities, and in institutional changes needed to transform power relations. So there are other initiatives around social accountability, around sensitization of service providers, and also work with judges. You're absolutely right that we have known for over half a century why women die of maternal deaths. And it's not a big public health problem in the industrialized North. In many countries in this region, it's not a big public health problem. It's a problem because of two principal factors. One is the social and economic status of women in a society, and two is the functioning of the health system, which we were talking about before. Maternal mortality is very subject to social determinants, so early marriage of girls, lack of female education, lack of women's empowerment, countries where you find entrenched discrimination against women on a number of grounds, legal discrimination against accessibility to certain services like abortion. You see law as a social determinant of health. But it's also a problem that does not lend itself to magic bullet solutions vertically. You really have to deal with the health system. So you need to deal with access to contraception and skilled birth attendants, but you also need to have emergency obstetric care. So I think that's really the question that we're going to need to be grappling with in the coming years. Rights-based approaches to health are still reasonably new. We don't have a tremendous amount of experience fully operationalizing them. I mean, the technical guidance just came out in 2012. There have been pieces of operationalization. And I think now people are really starting to think about how would we measure impact. And not just in terms of, or at least in my view, it cannot be about saying there's a value added to taking a human rights-based approach in that it will accelerate reduction of maternal mortality or it will accelerate reduction of child mortality. I think we need to come up with different metrics. So, for example, in the technical guidance, I talk about how it's not about contraceptive prevalence rates or maternal mortality ratios. It's about enabling women to live lives of dignity, which includes going through pregnancy and childbirth safely. And the way we think about outcomes and how we want to measure those outcomes reflects, what we care about and what we will do. So I think we're still in a process of coming up with effective, appropriate indicators to monitor and measure what we really care about.